Tanisha Joseph. Dr. Joseph is an assistant professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine. Board certified in hematology and medical oncology, he specializes in treating patients with plasma cell disorders, including multiple myeloma and amyloidosis. She is also an active clinical researcher in the fields of multiple myeloma, amyloidosis, and bone marrow transplant. Dr. Joseph is a member of the Clinical and Translational Review Committee and the Discovery and Developmental Therapeutics Research Program at Wilson Cancer Institute. Dr. Joseph serves as the director of the Morbidity and Mortality Conferences with the Department of Hematology and Oncology. She also co-leads the Winship Summer Scholarship Program, providing high school students with a unique immersion and experience in a cancer research laboratory. Dr. Joseph was named the first H. Jean Corey Fellow in Leukemia and Bone Marrow Transplant prior to joining the faculty at Winship Cancer Institute, and she holds professional memberships with the American Society of Clinical Oncology and the American Society of Hematology. Dr. Joseph received a medical degree from the Ohio State University School of Medicine in Columbus, Ohio. She completed both her residency in internal medicine and fellowship in hematology and medical oncology at Emory University, where she served as the chief fellow in her final year. Dr. Joseph's research interests in the development of novel treatment regimens and strategies for patients with plasma cell disorders. Dr. Joseph's work has been published in many leading journals, such as the Journal of Clinical Oncology, Cancer, the Clinical Lymphoma, Myeloma, and Leukemia Medical Journal, and her clinical research has been presented at national and international hematology conferences, in addition to serving as a reviewer for the Clinical Lymphoma, Myeloma, and Leukemia Medical Journal. Please join me in welcoming my oncologist, Dr. Joseph.
Hi, everybody. Thanks so much for coming. Mom makes me look good. She could introduce me everywhere. Okay, so I love speaking at these. I think it's a really great opportunity to meet patients and really talk about what's going on in the world of myeloma. When I've spoken at these before, we tend to have a mixed group of people. So people who have a lot of experience and maybe people who are new. I geared this to really just talk about newer developments of myeloma and really focus towards patients who are familiar with myeloma, but I'm happy to change here, of course, to make sure that this is helpful for everyone. So before we go in, if I could just, if you're comfortable raising your hand, how many patients or how many people in the room are new to the world of myeloma? So within the last 6 months, this is a new thing that we're learning about. Okay, and what about people who, a couple years? Okay, what about 5 to 10 years? Over 10 years? Okay, all right. That's what I figured. So people who are pretty familiar with myeloma, and I think hopefully for those of you who are new to myeloma, also encouraging that we have many people over 10 years who are here in the room continuing to learn about myeloma and being treated for myeloma, presumably. So I'm going to go through it. I'm going to briefly touch on the diagnosis of myeloma. I'm going to start with talking about updates in smoldering myeloma, and then I'm really going to go through some of the new data about newly diagnosed myeloma, and then mostly relapse and new therapies. I'm happy to be interrupted, and of course at the end we'll have time for questions and answers. Okay? Okay. So just to review, how do we diagnose myeloma? So there's a spectrum of plasma cell disorders, from MDS to smoldering, and then multiple myeloma. Myeloma is a cancer of plasma cells. Everything before myeloma we call a precursor state. So essentially, smoldering and myeloma are benign, they're non-malignant, but it's confusing because you do have these malignant plasma cells, but it's not causing end organ damage. So to, by definition, have myeloma, you have to have myeloma-defined events, which are listed. I don't think I have a pointer. Can you see my arrow? No. Okay. So listed below, so CRAB, which is high calcium levels, kidney dysfunction, anemia, or lytic bone disease. That's classically what we think of as myeloma-defining events. About 8 years ago now, we added a few more criteria, recognizing that there's a group of patients that even before CRAB, they have these factors, they're called the SLIM factors, which are listed here under myeloma, that even before you have myeloma, if you have one of these, you have an 80 to 90% risk of progression in 2 years. So if you have one of these features, meaning more than 60% clonal plasma cells in your marrow, a free light chain ratio greater than 100, or more than one focal lesion on MRI, we go ahead and we treat those patients like symptomatic myeloma, even without CRAB, because CRAB is around the corner, right? So we're trying to avoid fractures, we're trying to avoid dialysis dependence. Everything without SLIM CRAB criteria, we classify into either smoldering myeloma or MDUS based on the disease burden. So that disease burden, I mean, how many plasma cells, abnormal plasma cells are in the marrow, and how much abnormal protein do you have in your blood and urine. So let's first talk about smoldering myeloma. Now, classically, smoldering myeloma is a subset of plasma cell disorders that we did not treat, that we observed for years and years. But what we know about this group of patients is very heterogeneous. So it's a big kind of group of patients with a large spectrum of disease. So some patients have a very small amount of disease and a low risk of progression, and there are patients in that same group who have a much higher risk of progression. And so we have worked in multiple risk stratification models over the years. This is the 2220 model, or the Mayo 2018 model, that was presented, I think at ASCO in 2019, and it was validated by the International Myeloma Working Group. And essentially, using retrospective data, 3 independent risk factors for progression from smoldering to myeloma were identified, okay? One was an M spike over 2 grams. Everyone knows what I mean when I say M spike? Okay, the abnormal protein in the blood that the myeloma cells are making, okay? More than 20% clonal plasma cells in the marrow, and a free light chain ratio of involved over uninvolved of 20. So if you have 0 of these risk factors, that's low risk smoldering. If you have 1, that's intermediate smoldering. If you have 2 or 3, that's high risk smoldering. And there have now been 2 large phase 3 and many ongoing clinical trials looking at early intervention in smoldering myeloma. So this is the Spanish study, which is the first study looking at treatment with lenalidomide or Revlimid, dexamethasone versus observation in patients with smoldering myeloma. And what we've seen here, we now have over 10 years of follow-up, is a benefit in terms of time to progression in patients who were treated with lenalidomide and dexamethasone versus patients who were not treated, who were observed, which is the standard of care, or was the standard of care. And now we have over 10 years of follow-up, and we see this MTTP means median or average time to progression. And so how much time did it take from going from smoldering to myeloma? So you can see for those who were treated with len and dex, which is up here at the top, that time to progression was 9 years as opposed to 2 years in patients who were not treated. And one of the criticisms or concerns about treating people with smoldering myeloma is that you're going to create more resistant disease, right? If you expose the patient to lenalidomide before they even technically have myeloma, then when they have myeloma, are we making them have more genetically resistant or more challenging disease to treat? And when they looked at that, this is median overall survival from time of progression. So meaning the patients who didn't get len and the patients who did get len, once they, from the time that they got smoldering myeloma to the next progression, was there a difference? And there wasn't. Meaning that being treated with len does not create more resistant relapse. And so the point is trying to delay that time to when you develop symptomatic disease. So the other trial was actually led by Dr. Lonio, which those of you who were treated at Emory, you might know him, he's the chair of our department. And this was a large randomized phase 3 looking at lenalidomide versus observation. The study design was a little modernized and a little bit more relevant, and clinically, particularly in how we treat patients in the US. And then patients were treated with len until progression. And again, there was a significant benefit. This blue line on top is looking at survival. Okay, and so when you look at these curves, and I'll try not to show you too many curves, but you're really just looking to see if there's a separation between the 2 curves. So the red line is patients treated or patients on observation. The blue line is lenalidomide. And so you can see those curves separate. There's a real difference in survival there, or time to progression. And moreover, when we looked at high risk versus intermediate versus low risk, those categories I talked about, you can see there's particularly a benefit in the high risk group, as opposed to intermediate, and low looks like there's a benefit, but that's very small numbers of patients. And so based on this study, we feel that there's a role of early intervention for high-risk smoldering myeloma. So if you're being seen at Emory, and you have high-risk smoldering, if you have smoldering myeloma in general, the first thing I do is re-stratify you. And if you have high-risk disease, we at least have a conversation about the role of lenalidomide. What I still think is appropriate is the battle track, because I think it's still a really evolving area, an area we're trying to understand. So we have 2 clinical trials open at Emory right now. One of them is this, which is another ECOG study. ECOG is just a cooperative group that kind of runs some of these larger national trials. And so this one is basically looking at daratumumab, lenalidomide, and dex versus lenalidomide and dex for 2 years. So instead of treating people until progression and exposing them to a live toxicity, which we saw in the previous trial, we're kind of limiting that duration of therapy. We've enrolled about 11 or 12 folks at Emory. Nationally, there's probably 40 to 50 patients on this study. And so I think this is a really exciting opportunity. So if this is something that you have, I think it's worth a discussion. The other trial we have is looking at iberdomide, which is basically a new version of lenalidomide. There are other trials looking, just for your knowledge, the trials we have open at Emory are really more kind of looking at prevention or delay the time of progression. There are ongoing trials looking to see if we can actually cure patients when they have smoldering myeloma. So essentially treating patients with smoldering as if they have myeloma. So this is one of the trials. This is the Spanish trial where you get carfilzomib, lenalidomide, and dex. You actually get a stem cell transplant, which many of you might have experience with. You get a little bit more carfilzomib, lenalidomide, and dex, and then you get maintenance. And not unsurprisingly, if you look at this top row here, ORR means overall response rate. You're seeing all the numbers in the 90 to 100%, right? That's just saying that people were, not unsurprisingly, if you look at this top row here, ORR means overall response rate. You're seeing all the numbers in the 90 to 100%, right? That's just saying that people who were treated with high-risk smoldering on the study, their myeloma goes down, right? It's effective. That's not surprising because this is very intensive treatment. But when you look at the survival, the progression-free survival essentially means the remission time. At 3 years, 92% of patients were still in remission. That was very similar to patients who were just treated with lenalidomide. And so we're just really not sure if pounding people with a live therapy with smoldering is really the way to go. So I think there's still a lot more to understand. And I think I encourage you, if this is something that you have been diagnosed with, to have a conversation with your oncologist about treatment options. And I still think observation is appropriate. This is the other trial looking at kind of a curative intent. So this is carfilzomib and daratumumab with lenalidomide and dex, followed by consolidation of maintenance. So again, much more intensive therapy than we would normally do for multiple myeloma. And this is kind of a list just to give you an idea of what an active clinical trial space this is. This is not exhaustive or up to date. So there's just a lot of work in the smoldering myeloma space, trying to understand how we can best treat these patients and intervene. Questions about this? I just wanted to touch on that because I think it's an evolving space and things that we don't talk about as much at these patient conferences. Yes, ma'am.
It's a question that's just popped into my head, so I don't quite know if it fits into that category, but all those drugs you just mentioned and the clinical trials, those are the results. Is the aim when you have people who you deem fit to go on these clinical trials, how do you decide which drug treatment is right for them on the clinical trial? And also, what is your aim at the start of the clinical trial? Is it to get people to remission of for 5 years or well, immediately, but I mean, or as soon as possible?
Yeah.
And at what stage do you say, okay, they've been taking this for like a year or two,
Yeah.
and nothing's happened, so they're on another clinical trial, mind you, they're still smoldering, or do we say, no, we don't do anything? So I'm trying to understand that.
Yeah. No,
What your initial aim is for the patient.
It's a good question. So I think there's a couple questions in there, so let me break it down. I think the first question is, what is the aim of these clinical trials? Each clinical trial specifically has their own endpoints in the way that it's designed. In general, when I'm putting a patient or considering putting that patient in a smoldering myeloma trial, I'm looking to delay, at the very most, possibly prevent the development of myeloma, depending on what trial they're on. For the most part, it's about delay. Okay. The second kind of piece that you're asking about is, how do you decide what treatment if the patient is eligible? For any clinical trial you go on, whether it's smoldering or relapsed myeloma, there's an eligibility criteria that the protocol designs. So there are certain eligibility that's beyond me that a patient would have to meet to go on to a clinical trial. The therapy is dictated by the trial, so I don't choose what therapy you get. A lot of the smoldering myeloma trials are either phase 1-2, meaning everyone gets the same thing, or if it's a randomized study, like the DETER study, which I just showed you, that's computer randomization. So to go on the trial, I would have to feel comfortable that you could tolerate either of those treatments, right? Otherwise, you're not eligible. If I really only thought you could tolerate one, then that's not appropriate, because I can't control what you're getting randomized to. Does that make sense? And then when you're on a trial, I think your last piece was, what if you're not responding, et cetera. That's also dictated by the trial, with the exception of you as a patient always has the right to come off the clinical trial at any time. That is your right. There's no legal obligation to stand at the trial. That is not what you have to do. For the most part, we keep patients on a trial until they stop responding. Right? A good question. Anything else? Okay, so let's move on to newly diagnosed myeloma. I think this is probably something that most people know. Just a review, when a newly diagnosed myeloma patient comes into the clinic, it's very important that we get information so we can appropriately risk stratify disease. And for the most part, what we're looking at, these are a list of different labs that we get predominantly on your bone marrow, as well as your peripheral blood. And it's trying to tell us more about your specific type of myeloma. And specifically, what type of mutations made that normal plasma cell become abnormal. And so FISH, cytogenetics, those are just words for what genetic changes does your myeloma have. And patients often ask me, is this my genetics? This is not your genetics. This is not something you got from your parents and gave to your kids. This is specifically the mutation that your cancer cell accumulated to become abnormal. Okay? And there are certain genetic changes that are signaling a more aggressive myeloma cell than others. So that helps us risk stratify how we're going to treat it. Because patients whose myeloma has a higher risk mutation, those patients need to be approached differently. Standard risk and high risk patients cannot be treated the same, because high risk patients will not respond as well to the same therapy standard risk patients. So this is something that your doctor might have talked to you about if you were newly diagnosed. And this is also ISS or RISS. It's called the International Staging System, or the Revised International Staging System, is something that we use to stage your myeloma. Now, the other thing I'm often asked is, what stage is my myeloma? I think the important thing to understand in blood cancers is a very different staging system than a solid tumor, right? So by definition, myeloma is a cancer of the blood and bone marrow. So your blood and bone marrow is everywhere already. People often think, stage 4 is the worst. So if you have breast cancer, stage 1 is in the breast, right? Stage 2 moves further, and you think of stage 4 as being the hardest to treat. Myeloma is already everywhere, so we don't treat it by where it is. We don't stage it by where it is. We stage it by how proliferative or how quickly those cells are dividing and the genetics. So it's just a different type of staging system, and several other blood cancers are similar to that, probably the exception of lymphoma. So survival, just some updates. This is data from Emory that we published a few years ago. And so what we did is we looked, as everyone in the room knows, survival of myeloma has improved dramatically over the past 10, 20 years, which is fantastic. And that's largely in part to a lot of new drugs and development in the field. we wanted to kind of look at that specifically, and we identified 1,000 patients who were treated at our institution with RVD, or lenalidomide, bortezomib, dexamethasone. It's a common regimen that we use in newly diagnosed myeloma. Then we transplanted all those patients. This was retrospective, so we were looking back at patients who were treated like this. And then everyone got the same maintenance. And when we looked at those 1,000 patients, which is a very large number of patients, the average survival, MOS means median overall survival, was almost 11 years, which is pretty exciting, right? 11 years. And this was including patients, what year is it? Over 12 years ago that were diagnosed. So we have a lot of newer drugs and technology that these patients had access to. And I think moreover, I just want to draw your attention to the overall survival curve on the top, that kind of darker line. That's overall survival for standard risk patients. So when we tease out patients without high-risk genetics, median survival or average survival was not even reached at 10 years. 70% of patients were still alive. Okay? And I don't mean to be disheartened by the high-risk numbers because we are also treating high-risk patients a lot differently than we used to treat. But my point is that survival is very good at the moment and it continues to improve. And the reason it continues to improve is because of the rapid drug development and how many options we have for patients. And this is just an example. Long before I was treating myeloma, we didn't have a ton of options. And kind of in the early 2000s, there was kind of an explosion in conceived therapies. And this continues to this day. I couldn't even write all the drugs on here. And we're hoping to have another approval hopefully next month. So it just continues to grow. And I tell you this because I want you to feel comfortable that we're working hard at this and there continues to be more and more options every year. I will talk about some of these drugs, but these are words you might have heard before. These are some of the different classes of therapies that we have available in myeloma. So immunomodulatory agents or IMiDs. So many of you probably have been on lenalidomide or Revlimid. Pomalidomide is also an IMiD. The proteasome inhibitors like bortezomib or carfilzomib or ixazomib. We have monoclonal antibodies, daratumumab, elotuzumab. And now we have newer drugs with novel mechanisms of action, which if I have time, I will go through, like selinexor and venetoclax, as well as anti-BCMA drugs like belantamab, which we'll talk about. We have CAR T cells. Now we have 2 commercially approved CAR T cells, which is very exciting. Bispecific T cell engagers, which is what I'm referencing, should be approved soon. And then, of course, we use steroids in conjunction with a lot of these drugs. So I will reference some of these and we'll go over some of the newer drugs. So I wanted to talk about some of the presentations from this past ASCO and just update you on some of the newer data. So this is the determination trial. And this was this is the US version of another trial called the IFM trial. And essentially, I know this is busy, there were 2 arms. Patients either got RVD, which was like kind of that standard induction regimen, and then maintenance, or they got RVD, transplant, and maintenance. Okay? And then everybody got maintenance until progression. And so really this trial is looking at the role of transplant. In terms of demographics, some of the things that stood out about the trial, there were a higher number of African Americans enrolled in this trial than we often see in myeloma trials. I will tell you, Emory is an exception to that. We have a very similar enrollment in our clinical trials compared to how many patients we treat at our center. But in general, this is something, as the myeloma community, we continue to work on. ISS disease is just showing you between kind of standard risk and high risk patients, how many were enrolled, and kind of a typical distribution. Most patients were RISS or ISS stage 2. We always talk about AEs. I think not uncommon for people who have gone through these regimens. These are all kind of low blood counts, so certainly we see that. Some infection, fever, fatigue is very common on lenalidomide and pomalidomide. And then there was a little bit of a signal for AML and MDS, and this is always a concern for patients who are on lenalidomide for a long period of time. So we think about the rate of a second primary malignancy post-transplant on len, about 3 to 3.5%, which is why we're trying to think through who really needs to be on len indefinitely. But this is something that they talked about. So I think, unsurprisingly to us, because we are a transplant center and believe in transplant, the progression-free survival or the time in remission of patients who were in the transplant arm was about 68 months, versus the non-transplant arm, which is about 46 months. So the transplant arm was the red arm, and then the non-transplant arm was the blue arm. And then at the bottom, you can specifically see high risk versus standard risk patients. And I think everybody's benefiting from transplant, and particularly you can see high risk patients really have benefit from transplant. Without transplant, the remission is about a year and a half. Okay, whereas with transplant, we're getting out to 50 So I think really reinforces the role of transplant, particularly in high risk patients. I will tell you, my recommendation for most people is to consider transplant. There is a role for deferred transplant, and I think we can talk about that on a one-to-one basis. But for the most part, your myeloma is the most sensitive diagnosis, and you're the youngest you're ever going to be now. And so we try to give you that opportunity now. When we defer things, we can't really control what's going to happen down the road, and the state will be at relapse. So it's a general recommendation. One of the kind of concerns or a discussion points of this trial was that there was not a difference in overall survival. So there was a remission difference, but not an overall survival difference. And so some people concluded, well, maybe we don't really need transplant if the survival is the same. And our response to this is the follow-up of this trial is only a little over 6 years. And I showed you data. The red line is the transplant arm. It does dip, but it dips and recovers. So when I talk to patients about transplant, they say, how long am I going to feel bad? How long is this going to change my life? And I say, this is a temporary discomfort for a long-term life. Okay, so we're talking a month, maybe 2 months. And every day, for those of you who've gone through it, hopefully you can back me here, it gets better with time. And I'm not saying it's easy, but it does get better with time. And I think in the long term, when I'm talking about 6, 7, 8 years potentially remission, we're talking about a couple months. Really a couple weeks, maybe you're really feeling at your lowest. Hopefully, people agree with me on that. And so some of the key findings, there's a lot of findings on here. I think I'll just, what I take from this, I think this trial confirms the role of transplant. This trial confirms the role of continuous maintenance. I think there is a role for deferred transplant in young, standard risk patients who have good disease control. But again, I think that's a one-on-one discussion. It has to be personalized. That's not something that would be addressed. Do more than just lenalidomide maintenance in certain patients. So for high-risk patients, we routinely do triplet maintenance. And we at least do that for 3 years. Because when we looked, there was retrospective data that Dr. Nuka from our institution published in 2016, that when we treat patients with high-risk cytogenetics with just lenalidomide, they progress earlier. So we try to deepen that response by giving them slightly stronger maintenance therapy. And so routinely, I think that needs to be a PI in the backbone. I think newer data with the Forte study, which I believe is in here, we tend to do carfilzomib. Carfilzomib is an IV proteasome inhibitor that's very potent and it's effective in high-risk disease. And so we tend to do carfilzomib with lenalidomide, dexamethasone, which I try to taper down, which is the maintenance setting. And we tend to do that for 3 years. If you stay in remission, and particularly if you have deep remission, so meaning MRD negativity, then I talk about coming out of Revlimid every 3 years. But I don't routinely just do lenalidomide for high risk, and that's what's due.
Okay, I'm plan of the person that has this diagnosis. Is this in 2021?
Mm-hmm. so she was asking, basically the question is, my friend's been diagnosed with myeloma, they've been through so much, and now you're telling me I still have to go back on something, which is a common question and conversation. I think the challenge and things something I talk to patients about a diagnosis is kind of reframing your mind that you will be living with myeloma the rest of your life. So, and I know that's a challenge, but I think it's better than the alternative. So, we are working to cure myeloma. I will show you some data where, I think we're getting closer and closer every year, but right now it's not.
But the way we get that is by treating relatively continuously. And I think it's evolving where there are instances and circumstances where we can pull therapy into a response. In many cases, there might be people who are not on the right now. But, for the most part, we get those 9 medicines that are on the planet that continuing, and I think of it as continuing something, some kind of way for that myeloma. You just put on the gas. You take the foot off the gas, you're allowing that myeloma. There is some myeloma left, but we can measure whether or not it is there, like I said. So I know that's a very common thing around the mind, but I think that the clinician and kind of honest and
That's also important, and that's a conversation we have. Good question. Yes, ma'am.
I know with myself, I was at stage 3 myeloma when I found out. I had stem cell transplant. I had the chiroplasty done. And also about 2 years ago, I just went to my doctor and I said, I can't take this medicine anymore.
You can't take this?
I couldn't take that maintenance medicine anymore. It just was driving me nuts.
Yeah.
And it was bothering my stomach really bad. And so they gave me a break from the medicine. And so they just been checking my blood levels every 6 months. So I've been maintaining for the last 2 years, but I always worried in my brain that it could come back.
I think that's the challenge, and I think that's part of the individualized care. And I will also just caution, that's not something we would do for everybody. And I just want to be clear, because there are many different types of myeloma. And I think there's a specific patient that we can, thankfully, and hopefully you stay in remission, that we can do that in. But close monitoring is important.
Yeah, I go every 6 months to get checked.
Yeah.
And I've always been told that if I feel weak or really sick, just come back to the doctor's office.
Yeah.
But I don't want to come back.
I know.
And I worry about the maintenance now that I hear more and more about that.
You worry about the?
Like doing the maintenance.
Yeah. And I think the other thing to think about in maintenance, again, I'm a proponent of continuous maintenance. There are, we use lenalidomide a lot, we use doublets and triplets, but there are other things we can use. So if you really can't tolerate lenalidomide, we can have a conversation. Yeah. So I just briefly, I think I'm sorry, yes. How often do you have MRD testing? It's a great question. So it depends on the circumstance. So for someone who is newly diagnosed, we get a baseline sample on your diagnostic marrows. We can test it in the future. We don't routinely do it post-induction. We've started doing it post-transplant. So when we restage transplants, either 2 or 3 months post, we'll get it again. And then we get it at your 1-year restaging and then annually.
Oh, okay.
And then there are other circumstances and in clinical trials we get it at different places. Yes?
So the testing on your RMD, what exact test would you be getting for that?
What's MRD?
Huh?
Are you asking what is MRD?
No, well, I guess I'm asking what MRD is. I know what it does, but what are the tests that indicate where your status is?
Oh, I see. So when I say MRD, call it residual sequences. So they look for sequences of DNA for your specific myeloma that it can detect. So for example, it'll say negative, or it'll say we can still detect 200 copies or something like that. And I think negativity is obviously a great prognostic factor. I also look for the trend. So if you're MRD positive at day 60 and you have 100,000 copies, and then at 1 year you're down to 200, that's also a good sign, right?
And this is just malignant cells. This is not the genetic piece of it. It's just the malignancy of the cells themselves of myeloma.
Yes, so I think when you're asking genetic, we're talking about those high-risk features. We use a different test for that on your bone marrow, the FISH testing.
Okay.
Yeah.
Now, for the high risk, if you were diagnosed and your oncologist at the first diagnosis said that you're not high risk, does it change? Can it change over the years?
That's a great question. The question was, can you develop high-risk disease? And yes, the answer is yes. So you can accumulate high-risk mutations. The most common one to accumulate is something called LLS. In general, the more your myeloma relapses, it's functionally high risk because you're just developing a more resistant myeloma. It doesn't change how we treat that down the road. It's really more how we treat it up front. Because once you have myeloma that keeps coming back, we treat that in a similar way because that's just a myeloma that's starting to work around our treatments. Does that make sense? Good question. Anything else? Okay. I'm not going to be able to get through everything, so I'm just going to move through this quickly. I just wanted to kind of highlight some of the things on the horizon. So for standard risk patients, a common regimen we use for induction is daratumumab with RVD. For high-risk patients, we either use that regimen, RVD, or carfilzomib, lenalidomide, also called KRD. There is new data, this is a phase 2 study presented at ASCO, using DARA with KRD in high-risk patients. So in myeloma, you'll see we kind of continue to add more and more and more, particularly in high-risk, trying to get a deeper response. So I will kind of move through this quickly. The response rates were quite high. So you can see the overall response rate was 96%, which is great. That means 96% of patients at least had a 50% drop in the amount of myeloma they had from diagnosis to the end of induction. And you can see here the MRD negativity rate is about 62%. This is post-induction, which is good, okay? And so this is basically more work of how do we induce deeper and deeper responses in patients with harder to treat myeloma. I'm going to move through some of this. This is some of our MRD data. Okay, so I want to talk a little bit about novel therapies. I was assuming this is what people wanted to hear about. Please interrupt me if anything's unclear. So this is the belantamab mafodotin and belantamab from Myeloma, which some of you might have heard about. This was approved in 2020. It is an antibody drug conjugate. And so the way it's the first antibody drug conjugate we have in myeloma. The way I describe this is an antibody that's specific for your myeloma cell, and it's attached to essentially a chemotherapy agent. So it's directed delivery of chemotherapy. Is that in 98% of patients, the eye symptoms resolve when you hold the drug or delay the drug. the depth of response and other concern patients had, if you hold it, is my myeloma going to come back? So what happens is that response actually deepens, or is at least stable when we hold the dose. The more important thing is to not worsen the eye toxicity, that's not reversible. But by holding the dose, it almost always gets better. And I just listed some of the combination strategies that are in clinical trial, but we are actually using in the clinic. So some of you be on these regimens, belamaf in combination with pomalidomide or bortezomib. And so more to come, certainly with this drug, and probably moving that earlier in the treatment course than it is now. Currently, up to, I think, 4 prior lines of therapy. This is selinexor. It's an EXPO1 inhibitor. It's an oral drug. Oral regimens can be helpful. It can be, I don't know if anyone from Carrier Pharmacy here, it can be a challenging drug to give. There's a lot of GI toxicity. The original way it was dosed was at 100 milligrams once to twice weekly, and it really just wasn't tolerable. People had a lot of nausea, a lot of low appetite, weight loss, low sodium levels. And so by using selinexor to lower dose, combining it with other drugs, it's actually much more tolerable and pretty effective. And so selinexor with pomalidomide is a regimen I use, selinexor with bortezomib is a regimen I use. This is also for multi-release therapy, so we're talking about third or fourth line using selinexor as an option, but it can be very effective. And if we can find the right dose of selinexor for the patient, that's really the challenge. What we have started doing, let me see if I have another slide, is our pharmacist will, if you're on selinexor at Emory, our pharmacist, Dr. Maples, will meet with you and talk to you about an anti-nausea schedule, essentially. So if we're very proactive about nausea, then we can get ahead of it. We schedule nausea meds before you can take the selinexor, and then you have options to take it home. And I've had good success with that. So this is another promising option in relapse, right? So after you get through transplant, the myeloma's coming back. And then venetoclax is another drug. It's not FDA approved in myeloma. We see this a lot more in lymphoma, but it's particularly, we use it in the clinic, and it's particularly effective in patients who have translocation 11-14. So if that's a translocation that you've been told you have, this is something that I use in the relapse setting, either single agent with dexamethasone, or I combine it with daratumumab. And this is very effective. Some of the side effects are nausea and low blood counts, but we and some infection risk that we have to be cognizant of and manage. All right, so CAR T cells. Raise your hands, who's familiar with what CAR T is? I don't want to belabor this. Okay, so I'm going to talk about it. Okay. Dr. Romancic is familiar with CAR T, who just raised his hand. He's one of our lymphoma docs. So let's see here. Okay, so would it be helpful to talk about what CAR T is and how we do it? Okay. So essentially, CAR T is essentially, T cell is a cell in your immune system that can kill cancer cells. Okay, and essentially what CAR T cell is cancer has found a way to evade your immune system, right? It hides from your immune system, which is why it persists. So normally when you have a bad cell that pops up in your body, your immune system is supposed to kill it. And so the reason cancer is so tough, right, is because it's smart, and it can hide from your immune system and persist. And so these T cells that should be killing your myeloma cells, they don't anymore, because they essentially get turned off. So what CAR T stem cell transplant is a process of stem cell pheresis. So we put a line in you with a Gibson machine and we filter out your T cells. We then send it to a lab, essentially, where the T cell is souped up. So it's turned to a superhero T cell, which is now designed and kind of reinvigorated to kill your myeloma cells. So then what we'll do is we give you some chemotherapy to tampen down your immune response so that your immune system doesn't fight with new T cells. And then we infuse the T cells in you, again, very similarly to a stem cell transplant. So it's not a surgery or a procedure, it's an infusion, right? And then what we do is we monitor you. We do this in the hospital. So again, very similar to transplant. And you're in the hospital for anywhere to 7 to 14 days. And the reason you're in the hospital for that period of time is when we give you a big bolus of immune cells like that, your body can mount an inflammatory response. And it's called cytokine release syndrome. And we want to manage that in the hospital. Now, for most of these products now, it's very minor, it's grade 1 and 2 of this inflammatory response, and we have drugs to manage it. But we keep you in the hospital for at least a week for that reason, okay? We have 2 approved commercial CAR Ts in myeloma, cilta-cel or Carvykti and ide-cel. Right now, if you ask me which one would I use whatever one I get a slot for first, okay? Because they're newer drugs and we're working out the manufacturing process. They're similar in a lot of ways. And so this is something that for my patients who are relapsing on the second or third line, I'm starting to think about CAR T. The benefit of CAR T, why a lot of patients come and ask about CAR T, is it's one and done. In the sense that you're on CAR T, you get your CAR T infusion, and there's no maintenance. And we're seeing remissions anywhere from 8 months to 2 years, which is really great, right? For someone who's been on myeloma therapy for years and years and years, you go through CAR T, and then you could be 1 or 2 years without maintenance therapy. Where there's a lot of CAR T in clinical trials. I'm going to show you, this is some of the CAR T cells in clinical trial. Oh, here's a CRS setting, sorry. Let me move through how we manage this. So this is a CAR T, this is new, this is presented at ASCO. So the 2 CAR T cells we have target a certain antigen on the surface of your myeloma cells called BCMA. It's the same thing that belamaf targets. And what's kind of new or novel is looking at CAR T that targets different surface antigens. So this targets something called GPRC5D. It's on the surface of your myeloma cells. The reason this matters is if we keep targeting BCMA, we have a lot of BCMA drugs. So both of those CAR T cells target BCMA. All these bispecifics that are coming out, they target BCMA. Belamaf targets BCMA. We can't keep targeting BCMA. It's going to start becoming less effective. So having these same types of therapies that target other things, right, kind of switching it up on your myeloma, keeping it on their toes, that's going to be more effective. And so this Polaris study was presented at ASCO. Let me just go to some of the pertinent factors. 50% of the patients had received prior CAR T, BCMA CAR T, okay, which is important. And we're still seeing, this is a CRS rate. Again, almost everyone has CRS, but it's usually grade 1 or 2. When I say grade 1 or 2, that means fever and then your blood pressure drops a little bit and we manage it. Okay, 1%. But the overall response rate was 100%. Right? So even in patients who've already received CAR T, we're still very high response rates. Okay. Questions about CAR T? I know that was fast. Yes, ma'am.
So if you have CAR T and you're in remission for, let's say, 2 years, now what have CAR T is?
Yeah, that's a good question. So right now, no, I probably would not do another CAR T. I think that will change as we have CAR T with different targets. So that's a question maybe we could talk offline. It depends on what you've seen before. But now we're kind of looking at clinical trials.
Why is there a difference?
So good question. He was asking why the duration of response was different for the 2 CAR T cells. They're different products, the constructs are different. So it probably has to do with persistence of each of the products, how long those T cells remain viable in the patient's body. So they have to persist, so they keep working. And so we're in the clinical trials, a lot of the clinical trials in CAR T, there's kind of 2 buckets. One is making a more effective CAR T construct that's more persistent and effective. And the other bucket is combining CAR T with other therapies. So there are trials looking at CAR T with maintenance therapy. So doing CAR T and then putting someone on LEN, which in my mind makes more sense to try to extend that response. Or using CAR T earlier in therapy. So everything, right, when we look at clinical trials, we always have to look at the relapse refractory space. The FDA is not going to let us try new drugs as first line. And then they move up. So CAR T was approved in the relapse refractory space for more prior therapies. There are ongoing trials in transplant, and you do not have an optimal response. So patients who are not in a complete response post-transplant, trying CAR T then, and trying to solidify that response, get a deeper response then. Because patients who are not achieving a deep response post-transplant, they're already set up for shorter remissions and shorter survival. was, do you think transplant's going to be replaced? Transplant's been around a long time, and I still think there's a huge role for it. I think probably as we become more effective with CAR T and some of our immunotherapies, I hope it will be, and it probably will be. But I think we're not quite there yet. Yeah. But I think that's a question we're always asked, and I think probably yes. Yes.
CAR T is 100% effective.
So sorry, that was that one product in 18 patients.
Oh.
But it is
That's
effective.
good.
It is an
Okay.
effective therapy.
So it's been out, it's been studied, what year was that, did the study start?
So I think the two products that are approved have been studied in multiple different studies. I don't remember when the study started, probably 5 years ago.
Okay, thank you.
Okay. I wanted to try this another time. All right. So let's talk about some things that I think are exciting. So who's heard about bispecific antibodies? Or BiTEs? Okay, I see one hand. So bispecific antibodies are kind of the newest way of therapeutic development now. Bispecific antibodies or BiTEs, and essentially they are two-pronged antibodies. One prong attaches to your myeloma cell, and one prong attaches to a T cell, brings the T cell to the myeloma cell for direct cell death. So it's essentially a CAR T cell, but instead of having to go through manufacturing the CAR T cell and everything, it is an off-the-shelf product. The difference is it's not a one and done. So this is a more standard therapy where you're getting this weekly or every other week intravenously. There is still a risk of CRS, which is that inflammatory response I talked about in neurotoxicity, but that tends to be in the first cycle or two. It's usually low grade and it goes away. So for a lot of these, bispecifics are still in clinical trials for now. For a lot of these, if anyone's on a bispecific trial, you will probably hospitalize for that first or second round, and then we can start doing them outpatient. So these are some of the drugs, the bispecifics that can have the most data. Teclistamab is a Janssen product that I'm referencing is likely to be approved in the next month. The other ones that we have currently open at Emory, teclistamab we have as single agent. There's also other arms of the study where we're combining teclistamab with other agents like daratumumab and moving that into the earlier space, not just multiple relapses. We have 93269 at Emory, Regeneron, which is quite effective, and elranatab, I can't say that one, which is in the magnetism study. So this is a majestic trial, and this is looking at teclistamab. What I wanted to highlight here is the overall response rate. So when we look, which is 63%. So all of these bispecific antibodies, there's multiples, some target BCMA, some do not. For the most part, all the response rates are in 60 to 70%. And that is very exciting because usually when we look at drugs as monotherapy, like single agent drugs in the relapse refractory space, response rates that we are happy with is usually 25 to 35%. So belamaf had a 33% overall response rate. And that was really good because these are patients who've had 5, 6, 7 lines of therapy, and we're still seeing a response in a third of those patients. So if you compare that, now we're having these drugs that 60 to 70% of patients are having response rates in the relapse refractory space. It's very exciting, right? So thinking about moving that sooner when the disease is more sensitive. This is the magnetism study. So this is the other BCMA bispecific. There's two cohorts, patients who've had prior BCMA and patients who have not. The data that's been reported about patients who have not had prior BCMA. If you look, this is classic of any clinical trial in relapse refractory myeloma. The average number of therapies, which is highlighted at the top, is 5. Right? So these are heavily pretreated patients, and look at the range. Someone on there had 12 prior lines of therapy. So that's a very resistant myeloma that's included in these trials. And when you look at refractory status, 95% of patients are triple class refractory, meaning a refractory to an IMiD, PI, and a monoclonal antibody. And hence drug refractory means you're refractory to lenalidomide, pomalidomide, bortezomib, carfilzomib, and daratumumab. Right, so these are very refractory patients. And I'm saying this in an encouraging way because we've seen all these drugs, we're still seeing a really high response rate with this single agent. moving through here. I just want to get to your questions. Again, overall response rate is 60%. So looking forward, some of the drugs I want to highlight that are in clinical trial, we have these over in Emory and other centers around the country. So novel IMiDs, we call them cell mods. They're basically the grandchildren of lenalidomide and pomalidomide. So they're called CC220 or CC92480. And then really the drug names are going to be iberdomide and mezigdomide. Not clinically approved. Very effective and potent. So a lot more potent than lenalidomide and pomalidomide. In preclinical studies and now in patients with relapsed refractory disease, both of these drugs are being studied as monotherapy and in combination now with other drugs like daratumumab and bortezomib and carfilzomib. As monotherapy, we're seeing response rates kind of in the 20 to 30%, 26% was iberdomide or dexamethasone. And of course, that's increased when you put that with other drugs. So I think very exciting space. It's an oral agent. Actually, I've heard of mezigdomide is not, but an exciting option for parents, right? So as you get more and more, that's when you need more drugs. And then non-BCMA bispecifics, I talked about a non-BCMA CAR T, right? We need bispecifics that target other things. Cevostamab and talquetamab are currently in clinical trial quite effective and are targeting other antigens outside of BCMA. This is something that we can use as progression agent. So a lot of options in the future. So this is more about iberdomide and mezigdomide. Better tolerability, that's a point I want to make. So in comparison, I think probably everyone in the room has been on lenalidomide, maybe. A lot of things we see are hematologic, meaning blood count issues. A lot of people complain of fatigue, just not feeling good on Revlimid and POM. Diarrhea, low appetite, change in taste buds are kind of the things I hear the most. When we look at these drugs in relapsed refractory myeloma, so patients who have been through a lot, right? We're seeing really good tolerability. So the side effects that we're seeing are predominantly hematologic, which for us as hematologists are very manageable. And these are patients who've received a lot of therapy, so their bone marrow is retired, so that's kind of hard to report. But outside of low blood count issues, we're not seeing high-grade side effects, a lot less fatigue, a lot less GI toxicity. So very encouraging. This is cevostamab, so again a bispecific. It's targeting an antigen called FcRH5 on the surface of myeloma cells, and FcRH5 and CD3, bringing those two together. Very effective drug, ongoing phase 1 study. Overall response rate kind of depending on the dose, but you get anywhere from 50 to 60%. And then lastly, talquetamab. So again, another bispecific, response rate 60%. So very exciting and a lot more to come on this drug and really all the time. And that is what I had for you. So hopefully giving you some kind of overview of how we approach things and some of the more recent updates and what's going on. So thanks very much for your attention. I'm happy to take questions. I'll stick around after.
Do you see any of these new drugs similar to replacing Revlimid?
The question was, do you think any of these drugs will replace Revlimid?